In the criminal justice system, the people are represented by two separate yet equally important groups: the police who investigate crime and the district attorneys who prosecute the offenders. These are their stories.
Yeah, this is Officer McGinney, responding to a call we got earlier. We heard about some loud partying going on, some disturbances going on over in this neighborhood. This neighborhood right here is known for a lot of its illegal activity and underage drinking and partying. So this looks like the residence right here. It's a lot of cars. Gonna take a look. Looks like the place right here. 10-4, I'm responding to the disturbance right now. What we have here. How you doing?
Can I help you?
Yes, I'm Officer McGinney.
Okay.
Can I come in?
Yeah.
Okay, here's my badge.
Okay. Oh, okay. Okay. Help
Excuse
yourself.
me.
I'm sorry. I'll
Hello,
get out the
everyone.
way.
I'm Officer McGinney. Whoa, hey, whoa. Are you doing, sir? Are you doing illegal drugs?
What?
Put your hands behind your back. Put your hands behind your back. Stand up. Stand up. I'll be back for you. Come this way.
I do shit.
Hello.
How you doing?
How are you today?
You alright?
Can you state your name for me, sir?
Call me Big J.
What does that stand for?
Just call me Mr. White.
So why were you running at the party?
I don't like dealing with you donut eaters.
Well, stay on task, sir. So were you doing any drugs at the party?
Nope.
Don't lie to me. I caught you red-handed.
It's hot in here.
You're not getting off that easily.
I don't feel good. So much mess is starting to hurt.
Why were you doing drugs?
I can't feel my arm.
Don't. That's what happens when you do cocaine.
No, seriously, I think I need help.
You need help? Somebody call the ambulance.
Alright, so there are several mechanisms by which cocaine can lead to a myocardia, ischemia, and/or myocardial infarction. Cocaine acts as a powerful sympathomimetic agent by blocking the reuptake of norepinephrine and dopamine. This will lead to increase in heart rate, blood pressure, and contractility, which will result in increased myocardial oxygen demand. Cocaine use also causes increased vasoconstriction. This is due to the stimulation of alpha adrenergic receptors in the coronary muscles, increased levels of endothelin-1, and decreased production of nitric oxide. The vasoconstriction will result in decreased oxygen supply. Cocaine use can lead to acute thrombosis of coronary arteries. This may be mediated by increased plasminogen activator inhibitor. This will lead to an induced prothrombotic state because of increased platelet activation, platelet count, and platelet hyperaggrability. Cocaine use can also accelerate atherosclerosis. Cocaine users have been found to have elevated levels of C-reactive protein, von Willebrand factor, and fibrinogen.
I have to say, this isn't uncommon. Blow, which is a slang term for cocaine, is the second most commonly used illicit drug in the U.S., and its use causes the most ED visits. We commonly see this in young, non-white smoking men. The patient will typically present with chest pain and increased heart rate and blood pressure. Upon presentation, the patient will also usually have dyspnea, anxiety, palpitations, dizziness, and nausea. The initial chest pain could be caused by MI, aortic dissection, pulmonary hypertension, or crack lung. Crack lung is a rare pulmonary syndrome involving hypoxemia, hemoptysis, respiratory failure, and diffuse pulmonary infiltrates. In this case, it seems that the patient is experiencing MI because his left arm pain, excessive sweating, dyspnea, dizziness, and palpitations. If an MI is going to occur, it will usually happen within 1 to 3 hours of cocaine ingestion. Unfortunately, that fits our patient's case. Hello, Mr. White. My name's Lauren, and I'll be the one taking care of you today.
Okay.
Do you know what you're here for?
I don't even know. You know, last night I was at some party, and I don't know what happened after that. That's the last place I remember being.
All right. Well, I took a look at your labs, and it looks like you had a cocaine-induced heart attack.
What?
Yeah.
How?
To put it simply, it made your heart work too hard, and then it caused your body to have a lack of oxygen.
Okay. Well, what's the treatment? Like, am I gonna be on medications the rest of my life, or is it gonna affect my cocaine use? Because I'm not ready to stop using cocaine if that's the case.
Well, we're gonna need to keep you overnight and do a cardiac catheterization, and that's the first step. And I have a pharmacist that is on duty that's going to come in and explain the rest of your treatment plan for you. But for now, I'm busy, so I'm going to have to take off, and she'll be right in with you.
Okay.
So as far as diagnosis goes, it can be a little bit tricky. Usually when patients come in and they've been using cocaine, they won't admit it. I think Mr. White was a little scared and he went ahead and fessed up. When we see a patient that won't tell us if they've been using cocaine or if they do volunteer the information, we typically do a urinalysis. When doing so, we're looking for the cocaine metabolite called benzoyl-gonine. If the level is greater than 300 nanograms per milliliter, it's indicative of cocaine use. Aside from the urinalysis, evaluation of a patient with cocaine-induced acute coronary syndrome is generally the same as a patient with non-cocaine-induced acute coronary syndrome. We use ECG serial cardiac markers such as troponins and most commonly dobutamine stress testing to evaluate the patient's status.
Patients with cocaine-associated chest pain, unstable angina, or myocardial infarction, MI, should be treated similarly to those with traditional acute coronary syndrome, or ACS, or possible ACS, with a few notable exceptions. No randomized placebo-controlled trials regarding therapies to improve outcomes of patients sustaining a cocaine-associated MI have been reported. Therapeutic recommendations are based on animal studies, cardiac catheterization studies, observational studies, case series, and case reports. Unlike patients with ACS unrelated to cocaine use, cocaine users should be provided with intravenous benzodiazepines as early management. In the setting of cocaine use, benzodiazepines relieve chest pain and have beneficial cardiac hemodynamic management of neuropsychiatric manifestations favorably impacts the systemic manifestations of cocaine toxicity. In animal models, benzodiazepines decrease the central stimulatory effects of cocaine, thereby indirectly reducing cardiovascular toxicity. Hello, Mr. White. How are you doing?
I'm all right.
All right, I'm the pharmacist on duty today, and I heard you was a little concerned about your medications.
Yeah.
All right, well, I'm going to set you up with an IV here. We're going to give you some nitroglycerin that's going to help you with your pain, and it's going to help lower your blood pressure. Your blood pressure is pretty high right now. We're also going to give you diazepam, which is a sedating agent, which is also going to help with your increased heart rate, and it's also going to help with some of the pain that you're having. It's going to help keep your blood pressure down. We're running a fever, so we're going to give you some Tylenol to help bring your fever down a little bit. And I just wanted to ask you, were you planning to continue using cocaine, or was this it for you?
I've been thinking about it. I think it's time to quit.
It's time to quit? Yeah, I think that would be best for you. I'm actually going to recommend you to, I can actually set you up for a program if you need to get some drug abuse counseling. It's very, very important that you really try to stop with the cocaine use. It's really just put you in a situation where you could have almost lost your life.
Okay.
And also due to this situation, you're going to be on some medications for about a year, and you're also going to be on aspirin for life. So that we'll start with aspirin, and the aspirin, this is the one that you will have to be on indefinite, and it's going to be aspirin, 81 milligrams, and you're going to have to take that one time every day.
Okay.
And then we're also going to put you on clopidogrel, which is a blood thinner to help to prevent you from getting any blood clots, and you're going to have to do that 75 milligrams. We're going to give you a 75 milligram tablet. You're going to do that every day for 1 year.
Okay.
All right. You want a cholesterol lowering medication, which is atorvastatin, which is going to help with preventing further cocaine and further heart attacks or any other type of heart problems. So we're going to put you on atorvastatin 80, and you're going to take that 1 time daily. And we're also going to put you on a beta blocker, which is going to also help with the increased heart rate. And we're going to put you on labetalol 300 milligrams. You're going to take that 1 time daily. And then we're going to put you on an ACE inhibitor, lisinopril. And you're going to take that, and it's going to be 5 milligrams, and you're going to take that once daily as well. Okay. Did you have any questions for me?
I think it's pretty clear.
Cocaine-associated chest pain is treated with aspirin, IV benzodiazepines, IV nitroglycerin, and nitroprusside for persistent hypertension. If patient has contraindication to nitroprusside, an alternative would be phentolamine. In high-risk patients, they can either have STEMI or NSTEMI. STEMI is ST segment elevation myocardial infarction, and those patients would be treated with a primary percutaneous coronary intervention. In STEMI patients, non-ST segment elevation myocardial infarction will be treated with cardiac catheterization. In both, you want to avoid beta blockers acutely, and you want to use antithrombotic and antiplatelet therapy as indicated by existing guidelines. For those patients that are low moderate risk, you would want to observe those patients in the chest pain unit, and you would want to initiate drug abuse counseling. You can do stress tests if wanted, and you can either treat those inpatient or outpatient. Discharge therapy, we would want to definitely give patients aspirin, clopidogrel, a statin, or ACE inhibitor as indicated by existing guidelines, and we would want to consider beta blockers. Always consider drug abuse counseling.
You gonna do? Yeah. Bad boys, what you gonna do? What you gonna do?